Hello, everyone. Happy New Year. We might get the session started. So good evening and welcome to our 6th echo session of the Enhancing Palliative Care series. I hope you all had a lovely Christmas and New Year and all excited to start back in the process of completing our project ECHO. This session will focus on grief and bereavement and will be presented by Elizabeth Wright and Sam McDonnell. McDonnell, I hope I said that correctly. Okay, so we'll start with the acknowledgement to the country. We acknowledge the Kaurna peoples who are the traditional custodians of the Adelaide region. We pay tribute to their physical and spiritual connections to land, waters and community, enduring now as it has been throughout time. We pay respect to them, their culture and to elders past and present. We would also like to acknowledge and pay respect to those Aboriginal and Torres Strait Islander people from other nations who live, work, travel and contribute on Kaurna country. So welcome. My name's Leanne and I will be co-facilitating tonight's ECHO session and with Dr Russell Shute. I'm the General Manager here at GP Partners and also the Share Care Programs Manager. And as our project is supported by funding from SA Health through the Palliative Care 2022 grants program. The project is a 12-month initiative to cultivate communities of practice and establish continuous professional development and networking among GPs and palliative healthcare providers across South Australia who care for patients with life-limiting illness. If you haven't had a chance to check out our website page for Project ECHO yet, we encourage you to do so at www.gpaustralia.org.au. Just a little bit of housekeeping. Please introduce yourself in the chat. It's nice for you to let us know where you're joining from and your role. Your microphones are muted, but there will be lots of time during the session for questions and discussion. You're welcome to use the chat function to ask questions. If you have any comments or you're having any technical details, but feel free to also raise your hand. The didactic session will be recorded and will be emailed to you within the coming weeks. Remember not to disclose any personal health information during the session. And as always, we hope that you really enjoy the session. We'll just start off, as we always do, with perhaps just going around the table here with me so that we can introduce my team. So perhaps we'll start off with Russell and then work our way around.
Yeah, good everybody. My name is Russell Shute. I'm a GP at Malvern and GP lead for Project ECHO. So yes, nice to be starting again in 2023. So I hope everybody finds it useful because we've got two fantastic presenters tonight.
Hi, I'm Atif. I'll be providing IT support tonight.
Hi, I'm Naomi. I'm the ECHO coordinator and website management.
Yes. Hi, I'm Liz Wright. I'm the psychosocial lead with Central Adelaide Palliative Care. I'm here to find out more about ECHO and support Sam in the presentation because I'm getting some glory, but she's doing most of the presentation.
Hi, I'm Sam. I'm the bereavement coordinator with Central Adelaide Palliative Care Service.
And I'm Julian. I'm a pharmacist who's working with Southern Adelaide Palliative Service, rival service to CAPS now. And we're all friends. And I also work as an aged care pharmacist in Tanunda.
Excellent, thanks team. So I might hand over to Russell, who will start the ball rolling, introducing Liz and Sam, and we'll look at their presentation tonight for grief and bereavement in palliative care.
No worries. Thank you, Leanne. Hope everybody can hear me okay. So yes, well, Liz and Sam have saved me some work because they've already introduced themselves, but they're senior social workers with Central Adelaide Palliative Care Services. And I guess they can tell us a little bit more about themselves in a minute, but I think one of the there's a paragraph in the email you all would have received from Leanne, which I think is pretty critical, really, that, you know, everybody goes through this. Everybody's going to experience at some point in their life, they're going to experience the death of somebody close to them. Grief is a normal reaction to loss, but the course and consequences of bereavement will vary for each individual. And having just gone through this with my father-in-law and seeing the effect on my wife, son, and mother-in-law, it's particularly topical, and I'm not quite sure they have all received the care and support, but perhaps they could have. So I think palliative care does this particularly well. I think the palliative care services, you know, integrate psychological, spiritual, cultural aspects, and the bereavement support services are absolutely fantastic. So we're very lucky to have these guys share some of their wisdom and teaching. So thank you very much, guys, and take it away. And as we've said before, please put any questions in the chat, and we have got a couple of cases to present later that tease out some of the issues that we're going to talk about tonight. So don't be shy. Thank you, Liz and Sam.
Okay.
Sorry.
So yes, thank you very much for including us in the program. It's a topic close to my heart, so I can talk about it for a long time, which you probably will become apparent as I go on. Just in terms of setting the scene, I guess, I think as GPs, you may be supporting caregivers and family members as part of your care of a terminally ill person, but you might also be become aware of that any of your patients could be bereaved at any time as well. So not necessarily related to one of your terminally ill patients. So I'm hoping that you find the topic useful and that there's some things from today that you'll be able to consider as part of your practice and are likely to contribute to some positive bereavement outcomes for anyone that you see in your practice and bereaved. So just talking through today. So starting off with, I guess, a definition of bereavement, looking at some grief concepts, looking at how we screen for risk and protective factors, and how they can influence the grief response, and then looking at what grief support in the illness phase and after the death looks like. So it's quite a broad definition of bereavement, where we're including the anticipation of the death and also the adjustment following the death of a loved one. So it takes into account what's happening for families and caregivers during the patient's illness. In terms of some historical concepts of grief that have really had a lot of influence in terms of grief theory and concepts, there's a couple that I'll just talk to, which is the first one is Freud with his work in Mourning and Melancholia, and I guess his sort of key aspect of that was that a successful end to grief involved breaking ties with the deceased, and that was an energetic process of acknowledging and expressing painful emotions like guilt and anger. But his view was if people failed to engage or complete that grief work, recovery would be compromised, and they would risk mental health or physical illness. And so one of the key points from his model was stressing the importance of moving on, and with the aim of returning to normal functioning as quickly as possible. And I think we see that even today in terms of an expectation that we might have as individuals or the people around us have, that, you know, why hasn't grief gone away within a short period of time, and why aren't you back to normal? And then in terms of stage theories of grief also have wide appeal. They bring a sense of conceptual order to what is a pretty complex process. And there is the allure of something like a stage of grief that has a promise of recovery and closure from grief. Of course, Kübler-Ross would be the most well-known. But just wanting to, I guess, point out that her work was with the dying and was one of anticipatory grief, and that has been sort of more broadly applied to the grief experience, including bereavement experience, and also other forms of change and grief. And there is an implication that there is some sort of orderly progression through the stages, and not doing that can be problematic. It has been empirically rejected and widely criticised, but at the same time has become deeply ingrained and continues to be maintained in, I guess, the broader cultural awareness, society awareness, and even professionals still will draw heavily on Kubler-Ross. I guess one of the limitations of something like a stage form of stage grief is just its difficulty in terms of being able to capture the complexity, diversity, and individual quality of the grieving experience, and really thinking about grief in terms of quite a multifaceted response that includes the physical, emotional, behavioural, social, spiritual, and practical, and that bereaved people can have support needs in all of those aspects, including those practical support needs. In terms of some of the signs and symptoms of grief that as GPs are likely to see in terms of people presenting to you in your practice, there's obviously physical signs, which are pretty wide and varied, but there's lots of gastrointestinal sort of stuff around appetite, stuff around sleep, chest pains, shortness of breath, and I guess sort of pain as well that people can experience. There can also be some cognitive signs and changes for people who perhaps already have some cognitive decline. Lots of issues around memory and concentration. And then in terms of the emotional signs, pretty much the broad spectrum of emotions is possible in grief, and usually particularly in early grief at quite intense levels. But there can be, in amongst some of those really difficult emotions, some people can experience relief as well. But guilt and self-blame are something that is really quite common, and people can find themselves sort of ruminating and I guess having a lot of counterfactual thinking around things that they could have, should have, would have done better. The two down the bottom in terms of meaningless and hopelessness, I guess those are ones you need to pay attention to, and to be able to, I guess, unpack if people are starting to use those terms to check for possible suicidal ideation. And distress can come from a range of practical sources. The list is endless, really, but financial, housing, transport, work, commitments, or school and childcare can all be impacted by grief. I just put this slide in, which is because just, I guess, acknowledging that grief can have some similarities with depression. And sometimes it's difficult to sort of get a sense of what is going on. Is this grief, or is this depression, or perhaps a combination of both? And there's some sort of key areas where there is some distinct differences that can help sort of distinguish between one and the other. So I talked about some of those historical influences on grief in terms of where we sit now in terms of contemporary grief theories and concepts. There's a range that I've got listed there that are sort of widely recognised and drawn on. I don't have time to talk about all of them tonight, but if you are interested, there is, I recommend you to read Christopher Hall's Insight article from 2011, which was called Beyond Kubler-Ross, Recent Developments in Our Understanding of Grief and Bereavement. And Christopher Hall is from the Australian Centre for Grief and Bereavement. But one that I will talk about is the dual process model. That's something that I think is really quite helpful in terms of conceptualising what might be happening for people in grief, and also looks at, or I guess it helps to normalise some of the experiences that people who are grieving can have. So the dual process model, if you're not familiar with it, looks or considers the different stresses that are present arising from bereavement, and looking at them in two different orientations, I guess. One side is focused on the loss, so that's considering stresses that come from focusing on and processing the loss of the person who's died and the relationship aspects of that loss. On the other side, you've got restoration-oriented focus, and those stresses are about needing to continue on with the practicalities and challenges of everyday life, and that rebuilding and adjusting to life without the person, but also potentially needing to take on new roles, new responsibilities. Might be for something that the person who died used to handle, and now you're needing to step in and handle that as well. And that can be, really significant stuff for people. For instance, a married couple where the husband has done finances and he's been in charge of the finances, and he dies, and then the spouse is then trying to come to terms with bills and utility providers and everything else that comes along with that. So it's incredibly stressful. So really just acknowledging that wherever a person is in bereavement, it's stressful. And there is this, idea of needing to move between those two different focuses. And that process is quite a dynamic one and is seen as quite adaptive in grief. Both of them are stresses, but spending time in one gives you respite from the stress of the other, and that's the adaptive part of it. So when you see people who are able to spend time in both of those places, that's likely to be really facilitating sort of a normative grief process. If you see people who are stuck, particularly in one or the other, that might point to the possibility of some difficulties later on. Grief, I think, as Russell said, is a normal response to loss, and just wanting to acknowledge that most people experience grief which is painful and disruptive, but are still able to function in their daily lives and are able to integrate that loss into their life, particularly when they've got good support from family and friends in their communities. And importantly, most people will cope with grief without the need for professional help, and over time begin to adjust to the loss and to feel better. But of course, again, as Russell alluded to, some people are at increased risk of experiencing problems in the lead up to and after the person's death. So those people that we're worried about that might experience problems, what we're talking about there is bereavement risk. That there's this risk that they might go on to have an experience involving more intense and persistent symptoms of distress, and potentially some mental health problems as well. Things like prolonged grief disorder, PTSD, and increased risk of self-harm or suicide. So using standardised validated tools to diagnose prolonged grief in those that do have those persistent signs and symptoms is effective and useful, and can assist in facilitating referral for treatment. So in terms of screening for bereavement risk, and again, thinking about that as a process that begins during the illness phase and continues through to post-death. So in the illness phase, wanting to try to identify what are some of the risk factors that might contribute to someone having a more complex grief experience. But there's a problem in that there's actually not sufficient empirical evidence to support the use of any particular screening tool to screen for the risk of complicated bereavement. So that's a limitation in terms of risk screening during the illness phase. What is recommended is use of something like the distress screening thermometer to screen for psychosocial distress. So everyone would be aware of that in terms of its use with patients to identify patient distress, it can be modified to ask about carer distress. And so asking about it is quite a simple process, and then it's just a matter of trying to sort of, I guess, unpack what are the concerns that underlie that distress. And importantly, does the person need or want support for the issues that are causing distress? So we've got, I guess, distress that we've identified. How do we sort of link that back then to risk factors? Thinking about bereavement risk factors, there is so many that they tend to fall within one of those three categories: the intrapersonal, so what the person brings to that grief and bereavement experience, including their past mental health and coping history, previous loss history, and those sorts of things. There's interpersonal factors, particularly looking at the relationship between the person and their loved one. So the nature of that relationship, level of dependency, and sort of how, I guess, the nature of how central that person is to the bereaved person. And then also their relationships with their broader support network as well, and what does that look like? And then situational factors to do with the illness, the care, or the death, and the significance as well. So I guess it's really easy to get focused on all of the factors that might increase the risk of someone's grief becoming a mental health problem over time. But as mentioned before, you know, the majority of people cope with grief without needing professional help. So what is missing from the equation is really an awareness of resilience factors that people also bring with them to the bereavement experience. And those factors can be associated with a person's personal attributes. So things like being optimistic or having a positive state of mind. People sometimes have quite an internalized belief in their ability to cope, can sort of think of themselves as being stoic and strong. So those sorts of factors can help. And then also community and cultural factors. So thinking about spiritual, religious, or cultural beliefs that assist in the coping with the death, and also the level of connectedness that people have to those networks that are potentially an important source of support to them. And I just mentioned there's some research from McDonnell, who in his work really identified that resilience is the most common grief pattern, which is in keeping with, as we talked before, that the majority of people can cope with their grief with support from their natural support networks. So there's a whole heap of things that you can sort of notice about people that you might put down as resilience. I sort of won't go through them all, but yes, you can sort of use that as a bit of a guide to see is what you're seeing potentially someone who is quite resilient. In terms of grief support then, this is from the National Palliative Care Standards, notes that early identification and referral can improve outcomes for at-risk people, and anything that helps people prepare for the death, understanding the dying process, can reduce physical and psychosocial morbidity associated with loss and grief. Really important that what we provide is culturally appropriate loss and grief information, both before and after the death. And that when people are bereaved, that they've got multiple opportunities to access support, because it is such an individual thing that people will identify and feel like they may or may not need support at different time frames. So in terms of thinking about that and what we can do in the illness phase to, I guess, support caregivers who may be at risk, thinking about that anything that we can do to help prepare for the death. Things like having family meetings, conversations as a family, advanced care directive discussions, documenting the patient's wishes, conversations and planning around what the care is going to look like at the time of death. Can where the person wants to die be supported, so the site of care, and is there going to be sufficient support and care available to them? Having a clear out of hours plan is really critical for caregivers in the event that something, a concern comes up, or there's something, an unexpected change in the care of the patient that they're needing support around. So I mentioned before, the importance of having accurate information about what happens when someone is dying. That is, when that is not done, there's a whole range of symptoms that the patient might have that to witness it, if you're not expecting it, can be traumatic. So that is one of the things that makes a big difference for people. And then if there's other support needs, if you are able to, either referrals within your team, if you've got a multidisciplinary team, or looking at external referrals to try to address some of those practical support needs. And of course, if someone is incredibly distressed and is needing some specialist help, to look at those referrals as well. In terms of bereavement support after the death, so I have to apologise for this slide. So I was going to talk to the bereavement portal that was developed a couple of years ago. It used to have extensive information for bereaved people and for people caring for bereaved people, links to all sorts of credible information, resources, information about what was available in the way of supports. And I look today and it says for bereaved people to essentially go and see your GP. So it's not particularly helpful from that point of view anymore. But there is some useful stuff for you as GPs and health professionals in terms of some resources and some information. So instead, if you are bereaved, I'm just going to say at this point, you can.
Oh, sorry.
Yeah. I'm just going to plug the Australian Centre for Grief and Bereavement, because they've got a range of information that's in a variety of languages. There's a My Grief app as well, and again, there's information for if you are bereaved or if you are caring for someone who is bereaved. We are also in the process of putting together a booklet of all of the resources and groups, everything from I guess groups to mental health crisis response, information services, and a range of things. So it's out for consultation at the moment, but if once it is approved, I'm very happy to share it with you and share with the group. But in the meantime, yeah, you can't go wrong if you go to the Australian Centre for Grief and Bereavement.
And Sam and I are both been busy today. I'll try to find, I know the people who are responsible for the SA Health site. I'll find out what it is.
Yeah.
Maybe it's been redeveloped or something. Because it was very good.
Yeah, well, I was involved in the you know, the
Consultation.
well, the consultation and also the initial providing feedback about it, and it was really comprehensive. So I'm not quite sure.
We'll
what it's
follow up
called.
with that.
But yes, so in terms of bereavement information, what's really helpful is what grief looks like and feels like, indicators for complex grief or prolonged grief, and indicators for when to seek help is really important. And then also then information about what support is available. So that's the stuff that we will put together and hopefully share with you guys. So in terms of for people who do refer for support, I guess it's important in terms of the bereavement counselling that we offer to distinguish between what is the sorts of interventions and approach that we would take with people in early grief, where grief is quite normative, versus down the track where we're looking at prolonged grief and the differences between them. So in terms of early grief, within that first 12 months after the death, really focusing on grief being normal and a focus on normalising and validating people's experiences and not seeing it as a problem to be fixed. So trying to facilitate a continuation of normal grief through a range of different interventions, from as sort of straightforward as holding space to then some more stuff around psychoeducation and ways to cope with some of the intensity and emotional overwhelm that can come, some self-care strategies, and also importantly encouraging people to connect with their natural support networks, which is distinct from what we would do in prolonged grief. And for when we are considering prolonged grief, we're really looking at timeframes beyond 12 months. There's obviously variation in that and some differences in terms of cultural norms as well that factor in, but essentially the DSM-5 sets are at 12 months, so that's where I'll talk to. But yes, really at that point we're looking at therapeutic interventions to try to shift aspects of the grief that the person is concerned about and feels are problematic. And also co-addressing any mental health issues that sit alongside. And in terms of the interventions that we would use, there's a range of cognitive and behavioural approaches that have got a good evidence base for them. So CBT, ACT and family therapy. So I mentioned just about prolonged grief disorder, that it's now in the DSM-5, the revised text that came out last year. If you are looking for a diagnostic screening for this grief intensity scale, and we've got the website there that you can go to, you can fill that in online and it will sum everything up and give you a score and a recommendation as to whether the person is meeting the diagnostic criteria for prolonged grief disorder. So that's a helpful website. So yeah, that's a validated tool. And again, I think Russell alluded to this in his introduction as well. There is lots of access and inequality in terms of bereavement support. Palliative care services have bereavement support as part of their core business, but even within palliative care services, there's a huge variation in terms of how much resourcing is available to bereavement. And then, of course, bereavements that occur in other settings, the bereavement support that's available is even more ad hoc or absent. As GPs tend to be the sort of first point of call, the primary point of call for anyone in the community who is concerned about their grief. They tend to go to their GP, but there's issues around what's available in terms of grief support from GPs. With COVID, trying to get an appointment is difficult. There's short appointment times. There's differences also in terms of the relationships that people have with their GPs now, perhaps in comparison to how it's been in the past, where people will take the first appointment and to see whoever is available within a practice and doesn't necessarily have a consistent GP that they see. And of course, we can't know everything. So within GPs, you know, there's variable levels of knowledge and skills in terms of their capacity to provide effective grief support for people. And of course, in terms of then the referral pathways to see a psychologist or an accredited mental health social worker, there's the pathways pretty fraught. There's some stuff there around that it requires a DSM diagnosis and the risk of pathologizing grief for a good chunk of people. There's issues around cost, and the cost is now in the GP space as well, in terms of the availability of bulk billing, and huge wait times to see people, and also difficulty identifying a practitioner who has skills and expertise in grief as opposed to other mental health conditions is difficult as well. Which sort of leads to the case for a statewide bereavement service. COVID-19 has been a blessing and a curse. In terms of the negative impacts of COVID, they've been pretty rough on bereaved people for a whole range of reasons at various points throughout the past 2 years. From to put a positive spin on it, though, it's also increased, I guess, or highlighted for governments the gaps, the lacks, the limitations of existing bereavement support services. Really shone a light on that in early 2020. And from that, within SA, the palliative care strategic framework, and as I guess there's been identified a need for a comprehensive approach to bereavement in South Australia. So there's been a number of things that have happened in that space in terms of some funding that's been available. The bereavement advisory group has been set up and has drafted a bereavement plan. And there's been projects and programs across a few different areas. So we'll see what eventuates from that. But yes, something like a statewide bereavement service, like the equivalent, I guess, of the Australian Centre for Grief and Bereavement in Victoria would be amazing. And that's it for me.
Thank you.
Thank you very much.
Sorry, it's clearing my throat. Thank you very much, Sam. Fantastic. It's obviously a very complicated area, and you touched on, from a GP point of view, some of the issues, not just with people accessing us, but also us accessing psychological support, specialist support. I mean, I think that's always really tricky. And, relatively, the government's obviously changed the number of sessions that people can have through better outcomes and mental health initiatives. And I've always found it really tricky in a GP space to get linked in with a psychologist that, is really comfortable and, working with grief and bereavement. There's not everybody, it's like not every GP has this skill set. Not every psychologist is able to navigate that with families. Have you got any advice for GPs in that situation? It's just an impossible problem.
No, and I guess really my solution to that was that I provide that support myself, because I'm not aware of, a good number of people practicing in private practice that I would feel confident about referring to. My experience has been when I've done that in the past and received feedback from bereaved people about how it's been approached with them has been incredibly unhelpful. The difficulty is that it talks, if you were to go to the psychologist's website, find a psychologist, you can put in grief and bereavement, but everyone lists it amongst all of the other things that they do, and it doesn't have knowledge or specialty in it. And my husband, who's a psychologist, I realised at this point, he was still talking about Kubler-Ross as well. That was what was talked about when he did his training, and he hadn't sort of considered anything more recent than that. So and I would consider my husband an excellent psychologist. But grief and bereavement is not his area, and so he wasn't aware of where it in this current day and age, as opposed to happens where. And
we know some psychologists in Adelaide who do have a great deal of expertise in grief and bereavement, and they're booked out.
That's right. And it's very hard.
The cost is huge. For many people, it's and we can't be expecting any professionals to be acting this. No.
And of course, you guys have got your own limitations. You're completely slammed as it is dealing with palliative care patients and their families. And so externally referring, as from a GP perspective, a patient who hasn't been a palliative care patient per se, linked in with a tertiary service, we can't really do that, can we? We can't, you just haven't got the capacity to do that. So You know,
I mean, I'm in the process of doing my mental health accreditation now so that I could look at seeing people in private practice. But I was also aware that the PHN in terms of projects and programs is that sort of round of new programs and projects is the middle of this year, and I would love to put together some proposal in terms of a PHN funded program that is grief and bereavement specific. So yes, there's obviously a number of psychologist provided services through the PHN, but something more grief and bereavement specific would be wonderful to address that cost barrier, but then also having a referral pathway for the GPs that we be confident in as well.
Because there are some mental health accredited social workers as well, but again, they're very busy.
Tricky. But I think GPs do all this stuff all the time anyway. But it's just, I guess there are some situations, very complicated grief that we do occasionally throw our hands up in the air and we're not too sure what to do. Before I head now, there's a couple of case studies and they do pick up a lot on what we've already talked about, and we'll expand on some of the stuff that Sam's presented. Are there any questions, any concerns from anybody before we move on to that? Nope. So please, again, feel free to put anything in the chat. Leanne, are you happy for us to move on?
Yes, I think
so. For teaching us, for sharing their wisdom, and it is clearly a very complicated and highly nuanced thing. It's something we're all going to be confronted with. It's very important to get it right, and very, I think important to look at people as they're going through, especially in palliative care, as they're going through life-limiting illness, and making sure you're predicting and helping the families through that process to make sure that the bereavement process can go as smoothly as possible, but that's not always that easy. So thank you very much, guys. That was fantastic. And again, as we said, we're recording this, so it will be available. I have no idea about CPD for RACGP from 23 onward. I don't know, Leanne, you've probably looked at that.
It's a process, yes.
Have to record this as probably
get our head around it, and we'll probably send out or have something included in an email in terms of how that those hours can be used towards your 50 hours that you need to have for this current year.
Yeah.
So we'll do that. So I'll just mention before we do finish that in the spirit of continuous improvement, we'd love to get your feedback on how the session went. So we will be sending out another survey. So if you can fill that in and return it to us, that would be great. And as mentioned, the recording of the didactic presentation by Sam and Liz will be emailed out to you as soon as we can. And of course, we do hope to see you all again at our next session, which will be taking place on Wednesday, 15th of February, and again at 6:30. But in closing, I'd just like to remind you how important it is to get cases from you, the audience, and this will give us the opportunity to turn knowledge into practice and make these sessions as relevant to you as possible. So if you do have a case or an interesting patient, or a patient that's presenting a challenge to you that you would feel that some group chat will help you in managing that patient, please let us know. So as always, we attach the case submission form in our emails, and a copy probably is available, I think, in the chat. I think Naomi's already done that. So from my perspective, thank you all again, and we look forward to really getting these echo sessions up and away for the remainder of 2023. So thank you.